Good afternoon, everybody, and I'd like to thank Sabri for letting me be part of this very exciting instruction course. My task today has been made very easy by Dr. Juvenile, who's given a wonderful overview of how to approach orbital inflammation as well as its management. I'm going to focus on a group of disorders which are the specific orbital inflammations. They sound confusing, they're sort of rare. However, they have a very distinct implication for the patient's well-being. So it's probably worthwhile taking the effort and time to understand the disease and also help the patient understand the disease. How I remember this set of disorders is, first of all, I try to focus on what is common amongst all these entities. And then focus on what is different in each of these. So what is so specific about specific orbital inflammatory diseases? Each of these have very distinct histopathology. So we keep stressing again and again that biopsy is the way to go. And we have a specific pattern of organ involvement. So therefore the patient presents in a specific way. And obviously, as you've seen from the previous speaker, the treatment has to be tailored. We are looking at disease affecting the vessels, the vasculitis, granulomatous inflammation, sclerosing inflammation and IgG4 related disease, xanthogranuloma inflammation, and the set of disease called the transitional diseases. Among vasculitis, the major ones we focus on are Wegener's and Schwartz's. Okay? The second entity is very similar to Wegener's, however it's associated with asthma, and as opposed to Wegener's, which needs systemic immunosuppressants, Schwartz's needs only systemic steroids. Polyarteritis nodosa, is this pointed here? It's okay. And hypersensitivity angioitis are classical examples of vasculitis. Orbital vasculitis is often in response to a systemic illness, pre-existing viral disease or medications. It can be associated with other connective tissue disorders such as lupus or even with Cogan syndrome, very rarely. Typically on biopsy, you're going to see vessel destruction and there's endothelial damage, fibrin deposition around the vessels. And this may be immune complex mediated or hypersensitivity mediated. Now, here it's worthwhile knowing that the way I go about approaching these patients of orbital inflammation is that biopsy is the first step. And then my pathologist actually tells me that, look, this is what it's looking like. Why don't you ask for the blood test so and so? So if she sees a pathology like this, I would most likely ask for ANCA instead of putting the patient through the entire drill. Wegener's may be systemic or localized, and in the orbit, it is very often localized. If it is localized, the prognosis is better. There may be proptosis, there may be a destructive orbital mass. A midline lesion is more likely to be destructive, whereas a lacrimal one is more likely to be isolated. There may be a sinonasal disease, there may be hearing loss and other respiratory and renal involvement. Lacrimal gland involvement can cause dry eye. Other than that, the patient may have scleritis. This is one particular entity where orbital inflammation is associated with scleritis. There may be enophthalmos, bone erosion, and visual loss due to orbital vascular infarction. This is very often seen. In the last 3 years of the 4 Wegener's patients that I've seen, 3 of them have had some amount of visual loss. ANCA may be negative in the beginning. As the disease progresses, it may become positive, and as you treat it, it may become negative again. And when you follow the patient over some time, the other manifestations such as scleritis may develop later. The hearing loss may develop later. Cyclophosphamide is very, very effective, and you're talking about a time range of treatment of about 1.5 to 2 years. So, for me, Wegener's or vasculitis means these are diseases which are more painful than the other ones. There's more tissue destruction. There's a higher incidence of loss of vision. Next we come to the granulomatous inflammations, which could be including foreign body granulomas, including dermoid cyst-related inflammation, which is very common, and sarcoidosis as well as ulcerated sarcoidal inflammations. These will be having non-caseating granulomas. Very important to know, because given our frequency of Cox disease, we have to differentiate it from the caseating granulomas. These present more with a mass effect, so biopsy is commonly needed. They may be uveitis, chorioretinitis, conjunctival nodules, optic nerve sheath sarcoid, and skin nodules. If you look at systemic sarcoid, 50% have ocular involvement and frequently bilaterally lacrimal glands are involved. Whereas the patients that come to the ophthalmologist with the orbital involvement, about 70% will have mediastinal lymphadenopathy. There may be a sequential development of disease, such as this patient who developed dacryoadenitis, later on went on to develop skin lesions. And as the lacrimal gland lesion resolved, the higher lymphadenopathy increased and finally led to collapse and fibrosis of the inferior lobe. This patient, for instance, presented with a typical mass lesion. Now, this is one patient, very well distinct mass lesion, and this is one patient where clinically you might suggest to the pathologist that, okay, look, stain for the fungal elements also, because this will come into the differential diagnosis. She also had lymphadenopathy. Rarely, a sarcoidal orbital involvement may develop, optic neuropathy. Within a week of detection of the sarcoidal disease, she developed an RAPD and we had to start steroids very promptly. It's commoner than previously believed and it evolves over time. We need to differentiate it from Cox. Often pulmonologists, they keep arguing amongst themselves. Do we give ATD? Do we give steroids? Do we give steroids under the cover of ATD? There's not much published literature on it. What I've understood from the microbiologists around is the tests that are recommended, like quantiferon, etc., are not very effective for orbital Cox disease. The one thing that may be useful is a PCR. Sclerosing inflammation typically presents with extensive fibrosis in the orbit. The cellular infiltrate is less. The commonest source is the lacrimal gland, and it may be associated with systemic fibrosclerosis. Typically, the tissue planes are obliterated, it's infiltrated. It can extend outside the orbit, go into the paranasal sinuses, go into the temporomandibular fossa. And when you take the biopsy, you feel that it's a very hard mass. It's almost gritty. It's difficult to cut. This has a poor response to corticosteroid and radiation in 30% of the patients. But the earlier you start the treatment, the more likely that it's going to respond. IgG for related disease, I've tracked it together with this because now it's found that more and more orbital inflammatory diseases also associated with immunoglobulin G4, and particularly in plasmacytic inflammation and fibrosis. It may involve the lacrimal gland in 80 to 90% of the patients and may progress to lymphoma. In fact, it's so common, previously unsuspected. There was a group who went back and seen their old slides of, so to say, quote-unquote non-specific orbital inflammation. And they had to revise their diagnosis in 40% of the cases. That they found that it was actually all IgG4 related disease. And particularly when there's bilateral orbital involvement or multiple foci of orbital involvement, it makes sense to take multiple biopsies because it's a progressive thing. it's been reported that in the same patient, part of the disease may be IgG4 related inflammation, part of it may be a lymphoma. And the one differentiating feature that has been reported is that the part that has turned into a lymphoma enhances more on the MRI. So these are basically infiltrative disease and difficult to manage. And it's a new concept that there's an association of IgG4 disease with sclerosing inflammation and as well as lymphoproliferative disorders. Xanthogranulomatoous diseases are characterized by chronic inflammation with lipid-laden histiocytes and giant cells. These have a typical yellowish appearance. It may look somewhat similar to xanthelasma, but then you think, no, it doesn't look exactly like a xanthelasma, and there may be orbital fullness along with the patient, along with that. Now, these are the entities associated with that. And what I remember for each of this, because these are a set of very rare diseases, that juvenile xanthogranuloma affects mostly the uveal tract and sometimes the eye, rarely the anterior orbit. Adult onset xanthogranuloma may be associated with adult onset of asthma. Necrobiotic xanthogranuloma is associated with paraproteinemia, that is monoclonal gammopathies, multiple myeloma, and leukemias. And Erdheim Chester disease is associated with multi-organ involvement. Transitional disorders mostly have mass and infiltrative effects and can be actually included under lymphoproliferative disease as well. One of them is the Sjogren syndrome. By definition, any two of three involvement, lacrimal gland, that is dry eye, salivary gland, that is dry mouth, and autoimmune disorder would define a Sjogren syndrome. There's extensive destruction of the lacrimal gland acini along with inflammatory cell infiltrates. Tear levels may be low or normal. Always low in atrophic lacrimal glands, it may be normal in enlarged lacrimal glands. And there's a long-term risk of development of lymphomas. Rosa-Dorman is another disease which presents as orbital mass deletion, and there's massive histiocytosis with lymphadenopathy. And typically for the histopathology, it shows a characteristic called emperipolysis, with the histiocytes sort of eating up the polymorphonuclear leukocytes, a phagocytosis of that. And the treatment is steroids and immunosuppressants. So the diagnosis of the specific inflammatory disorders include local signs and symptoms, systemic signs and symptoms, histopathology, and serum markers. And it's nice to have a look at what the specific serum markers indicate. When you suspect Sjogren's, look at SSA and SSB, but SSB is far more specific. TSDNA is going to be positive in almost all of these disorders, but if you see systemic features of lupus, it's going to have a much higher positive predictive value. ANCHOR is positive in beginners, and you can actually monitor disease activity using that. ACE is positive in sarcoidosis. So the management of these disorders is a combination of steroids and immunosuppressants and continued monitoring for progress and adverse effects. We do need to do long-term monitoring. Patients may be late, and it's best managed as a team effort. I do acknowledge the efforts put in by my pathologist and my rheumatologist colleague in treatment of these patients. Thank you.